Can I have everybody in? Can I first call upon Dr. Hisham from WMA? Please do come in. I know he's very popular there. He's taking fake pictures. Thank you. Thank you, Dr. From the prison. Howard Catton from the International Council of Nurses. Howard, please do sit. Yeah, first. Yeah. Howard, thank you very much, Howard. Dr. Catherine Duggan will join us online, virtually. And could I call on Professor Lara Bloom, our board member, Lara? Hi. Yes. Sorry. Sorry, I was looking for. Thank you. Thank you. I thought you were still in the plane. Good. Then Nicola Bedlington is already at the tail end. And then we have Rod Padua. He'll be joining us online. He's a council member of the Alliance of Partners with Patients from APPIS and Middle East, and he's in Philippines this morning. Thank you very much for coming in. I have the double pleasure here, firstly of not only being a master of ceremonies, but also being the moderator for this session, because I thought this session requires great attention, because this is what we have been working towards, humanizing healthcare, making healthcare more accessible, making healthcare more compassionate, and making medical education more patient-oriented, having patient co-creation in medical training. So now the session heading is quite clear. We're saying in order to develop robust and resilient partnerships with health professionals to promote patient-centered and compassionate and humanized healthcare. So we are talking about developing those partnerships and those resilient patient approaches and health professional collaboration. I will take the saying of William Osler, who is quoted very often, that the good physician treats the disease and the great physician treats the patient with the disease. The patient-doctor relationship has been sacrosanct, and I was talking to Dr. Ocean about it, that there's something that we almost don't need to remind, but it's to appreciate this year. I think that's what we are doing today, appreciating. We know you have our best interests at your heart. But we also know that the areas that the pandemic revealed to us, practically it crippled our health systems and stressed our doctors out. Vice versa, in the World Patient Safety Day in 2021, the theme was about there is no patient safety without health professional safety. And I think we must take care of our doctors. These are resources who have taken 7 years and more to train, almost 13 years before, talking to us before they're allowed to ruin those motivations and careers and move doctors into the media. I think that's something you see. I always, when I see a doctor in the media, I say, why aren't you in clinical practice? That's why you're valuable, not on the red sofa. So without much ado, I will ask Dr. Ocean to come up and talk about the World Medical Association and how far are we near or close to the William Osler's quote that the good physicians treats the disease and the great physician treats the patient with the disease. Dr. Ocean?
Okay.
You can speak from there.
Okay. I thought I use this.
Yes, please.
My slides is not clear.
Okay, just say next.
How do I see it?
Probably easier to stand.
Yeah, so you're using it.
Yeah, thank you. Okay. Good morning, everyone. And of course, I'm told that there's some persons online, so it may be that they're also in their evening. So I say good morning, good afternoon, good evening, wherever you are, both online and physically. It's a pleasure to be here on behalf of the World Medical Association. My name is Dr. Osahon Enabulele. I'm the president of the World Medical Association, and I would like to just, in a few minutes, as I was requested, to quickly talk about our own approach and how we've been able to, of course, intervene in this whole concept of patient-centered healthcare. But of course, with reference to the theme of this discussion, which is developing robust and resilient patient partnerships with health professionals to promote patient-centered care. And so, just next slide, please. I would like to first introduce the World Medical Association because I do not want to make any assumption that we all understand what the WMA stands for. For the interest or for the information of those who may not know, next slide. The World Medical Association has been around for over 75 years. And of course, it came on board after the revelations of the Second World War, importantly in 1947, of course, September. And it's been around for over 75 years, like I said. And it's an independent international federation of physicians from all over the world, and currently has over 115 national medical associations. And of course, it has very core objectives centered on advancing universal access to care, and of course, advancing quality patient care, the whole issue of medical education, universal health coverage, of course, patient rights, the social determinants, and many other objectives, but cardinally, the issue of patient autonomy, physician autonomy, and of course, universal health coverage. And we have very many policy prescriptions and declarative statements that also impact on physician-patient relationship. Importantly, the whole evolution of patient-centered care. So that, in a nutshell, is what the WMA is all about. I thought I would use this structured outline, but for the sake of time, I may need to short-circuit this. I don't know how much time I have. Okay, I should carry on. Okay, fine, thank you. So I just thought I should do a brief on this whole concept of patient-centered care, particularly from the standpoint of the World Medical Association. Please, next slide. So I'll just use this outline. Next slide, please. So I've already introduced to you the World Medical Association. Like I said, it's been around since September 1947, and it's done very amazing, profound work in the whole aspect of advancing the relationship between physicians and patients, preeminently the evolution and development of patient-centered care. And those are the objectives of the World Medical Association, as I earlier outlined: universal health coverage, patient rights, physician rights and autonomy, medical education, and of course, other objectives. Next slide, please. Now, when we look at this whole concept of patient-centered care, like I said, the whole relationship between physicians and patients is not new. It's as old as the origin of medicine. But what has happened is that over time, there has been an evolution, a development, or rather a strengthening of this relationship, particularly with the shift from the paternalistic care model to, of course, what now is known as a patient-centered model that, of course, imbibes or integrates the biopsychosocial approach to medicine and, of course, the humanistic approach to medicine. So that increasingly is now a new paradigm in terms of the care approach, in terms of the care of patients, from a doctor-centered biomedical model to a more of a patient-centered model. And of course, there are a lot of changes that developments that, of course, triggered this new reality. Importantly, even as far back as 1948, with the Universal Declaration of Human Rights, the Declaration of Geneva, which is a patented document of the World Medical Association in 1948, which was recently reviewed in 2017, now known as the Visions Pledge. More like, trying to put into perspective the place of more compassionate, humanistic care for the patients in terms of their the commitment of physicians to the rights of patients. So this has given rise to this movement, importantly, along with other socio-economic, socio-environmental changes. So now we have, please move on to the next slide. So this is, so just to, this is what I've tried to do to say that it's not new. Next slide, please. And so right now the world is, engaging this whole concept of patient-centered care, and World Medical Association has been very profound and has been in the forefront of driving this through policy prescriptions. The patient-centered care, like we know, next slide, it's all about integrating the needs and expectations of patients in the care process. More like getting them to be part of the decision-making, part of the care process, even the planning, and the execution of that plan, an effort to reconcile the agenda of the physician, which in times of yore was more preeminent, with the agenda of the patient. So that everybody comes to the table, both the doctor and the patient comes to the table to reconcile that agenda in the overall interest of the patient. So the bottom line is how to advance the interest and the better health outcomes, for the population. So that's, in a nutshell, is what patient-centered care is. Next slide, please. And this, of course, has been, done through the support of some policy documents of the WMA. Importantly, we have what is commonly known as the Declaration of Lisbon, for instance, which, of course, talks about the rights of the patient. So the WMA has articulated this. So we are doing everything possible to advance this humanistic approach to care. And if you look at that Declaration of Lisbon, it emphasizes, for instance, the right to self-determination of patients, the right to quality health care, the right to information, health education, and so many other rights. So that's what we expect our physicians to get committed to, in as much as we also now expect them to also have their health and well-being also advanced in terms of even an expression of their professional autonomy, because it's about reconciling patient autonomy with our own professional autonomy in the best interest of the patient. So this is what it's all about, patient-centered care. Next slide, please. So the philosophy is, like I said, hinged on the whole idea of the biopsychosocial approach to medicine, the humanistic approach to medicine, and of course predicated on patient autonomy and the whole principle of justice. And of course, has core concepts of respect and dignity, information knowledge sharing, collaboration and participation of the patients in their care plan, and ability to negotiate even the care plans within the context of the family and the community. Next slide, please. So this all, talks about patient-centered care, and there are very many alluring benefits for investing in patient-centered care, and that is why the whole world needs to move in this direction, along with what the WMA is doing. Because unless and until we strengthen patient-centered care approach, we may not be able to reap the benefits in terms of the overall health outcomes that we hope to have, because it's been shown that effective, efficient execution of this approach to patient care would, of course, drive improved health outcomes. So there are several benefits. But I like to say that there are challenges that have buffeted this whole approach to care. One of which has to do with the patients themselves. We still have, in some jurisdictions in the world, very low health literacy, and of course, socio-cultural and economic issues, which have, of course, inhibited the ability of patients to, of course, involve themselves actively in the care process. So we need to, of course, focus on how to remove these barriers in various jurisdictions. But of course, we also have system issues. Of course, recently we saw it in during the COVID pandemic, the whole issue of workplace indecent working conditions, which of course does not make it enabling, for a proper processing of the patient care approach. So the issue of violence against physicians, the issue of burnout as a result of increased workload. In Africa, for instance, which is very, 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 preeminent in this whole direction. 25% of the global disease burden, but less than 3% of the global health workforce. In fact, Africa is said to have a deficit of about 5.3 million healthcare workers. In Nigeria, for instance, where I come from, sometimes, you have a doctor in some general hospitals seeing over 60, 80 patients a day. How do you expect that kind of doctor to execute the whole principle of patient-centered care? It's going to be difficult. So we need to address the human resource issues. We need to address the issue of the economic pressure on physicians as a result of, sometimes these managed care systems and all of that. We need to address the issue of violence. And the WMA, like I said, has put forward some policy prescriptions to help to redress the infrastructural issues, of course, the process issues, the system issues, and of course, there is need for us, therefore, to also be able to enlighten patients, importantly for those who have very low literacy levels, see how they can better actively participate in the care process. We need to, of course, sort out the infrastructural working place issues. And of course, I'm happy with the 5th Global Forum on Human Resource of Health that now emphasizes on the whole issue of decent working conditions, reducing the whole specter of violence against physicians and other health workers. Okay, you said the time is up. Okay, I thought you said I have all the time in the world. So let me round up now. So clearly, there are issues to be contended with, but I just say that it is a process and not a destination. The whole issue of driving robust partnerships with health professionals, between health professionals and patients, is a process and not a destination. So we need to continually work on this, look at the dynamics, and therefore, in conclusion, let's go to the next slide, the last slide. I like to say that, last slide, please. And let me conclude, since there's no time. Last slide, just go on. Yeah, go on. So it's a process which before this, please. I don't want my picture. Just go on. The one before the last. Looks like you are in love with this picture. Just the one before, please. Okay. In conclusion, I like to say that patient-centered care is fundamental to effective clinical decision making, but needs to be effectively practiced to engender improved patient satisfaction and health outcomes. To do this, we agree. WMA agrees that there is need for robust and resilient partnerships, patient partnerships with health professionals, as well as resolution of the misunderstanding about the concept of patient-centered care. There's a lot of misinformation still existing, and misconception about it, especially what determines patient-centeredness. That is a kernel. So the WMA this forum to reaffirm her commitment to the expression of our various policies that seek to protect the rights of patients, including their participation in their care plans. Thank you very much for this opportunity. God bless you.
Thank you very much. I think you've really laid the grounds for now. Great discussion and coverage. We saw at the head of the health system. Now we'll bring in the nurses' viewpoint. One of the questions we will save for Howard is, during the pandemic, we all came out on a Thursday or a Wednesday clapping hands and beating pans. Then we have the unfortunate sight of seeing nurses on strike. What happened? Howard will follow the thing. Thank you.
Thank you, Kawaldip. Good afternoon, everyone. Absolute pleasure to be here with you. Firstly, congratulate IAPO and Kawaldip. You are, without a doubt, a very strong and influential voice, which we regularly come across in our work here in Geneva with WHO and around the world. Next slide, please. My name's Howard Catton. I am a nurse, and I'm also the Chief Executive Officer of the International Council of Nurses. Next slide, please. Just so that you know, ICN is the body recognised by WHO to speak on behalf of the nursing profession. Our membership are national nursing associations. We have more than 130 associations in membership. There are about 28 million nurses right away around the world. Next slide, please. This document, our Code of Ethics, and I wanted to start with this because it is the most downloaded document from our website and the most requested document. It sets out the ethical basis for nursing practice. And there are two key points that I've highlighted here. Nurses' primary responsibility is to people requiring nursing care and services. An obvious point to make, but in recent weeks and months when I have been talking to nurses in Afghanistan, in Sudan, in Ukraine, in Myanmar, the bravery and the courage of some of our nursing colleagues around the world to uphold this principle is hugely impressive. But it's not right that healthcare facilities and healthcare staff continue to come under attack during conflicts. The other that I wanted to highlight here, where nurses face a dual loyalty, a conflict between their professional duties to the patient, to the public, and obligations to their employer or other authority. Their primary responsibility is to those who require care. This includes taking actions such as whistleblowing to safeguard human rights. So at the core of nursing practice, there is no doubt that people and patients come first, but this has been incredibly difficult for many, many nurses to deliver on over recent weeks and months. Next slide, please. I've mentioned issues around attacks, but of course we have just gone, and it's coming towards the end of the global pandemic. It has taken an enormous toll on the physical and mental health of nurses. This is our most recent report. It pulls together more than 100 studies from around the world about the physical and the mental health impacts. We have seen nothing like it before. The mental health impacts we have called the mass traumatization of the nursing workforce. This is down to our health systems simply not being prepared for the pandemic, and that means that there's been a failure to protect, to support, to invest in nurses and other healthcare workers. Your debate about the dehumanisation of healthcare systems for patients, I believe, applies equally to nurses and healthcare staff. In too many places, they are working in dehumanised environments. This is driving a shortage of nurses globally. We had a shortage before the pandemic. The shortage is getting bigger, could be running into 12 to 13 million. The global pandemic may be over as a public health emergency, but we have said that we believe that there is a global health emergency in relation to the nursing workforce. I think that applies to other parts of the workforce as well. Next slide, please. The next slide, please, just gives you some highlights from the report, just to the scale. Intention to leave rates up by 20%, actual leave rates of more than 10%. Nurses being overwhelmed with the emotional toll, poor work-life balance and moral injury. We have seen nurses suffering post-traumatic stress disorder, tragically who have committed suicide as well. And some of that organisation, some of that response to all of this worries me, because a lot of it involves a discussion around resilience, and a discussion which implies Nurse Kawaldip will give you some resilience training. You should be more resilient. Nurse up, woman up, man up to deal with these issues. I don't want to say that there is no place for resilience training. There is. But the real resilience that we lack is resilience of our health care systems. Not enough staff, not enough equipment, not enough investment. Next slide, please. Why does all of this matter? All of this matters because not having enough of the right skilled, qualified, educated nurses and other healthcare professionals creates increased risk to patient safety. We know from hard academic evidence, there's a great literature of this now that speaks to nursing, but I know it speaks to other professions as well, that where there aren't enough staff, mortality rates are higher, infections, trips and falls, medication errors, patient experience, what we call a failure to rescue, identifying quickly the deteriorating patient. But when we do have enough staff, not only is it a protective factor for patient safety, you also see that nurses feel better supported, protected, lower stress levels, lower illness rates, or absence levels as well. Two sides of the same coin. Next slide, please. Some of you might think, well, the nurse, the guy from ICN might say that, mightn't he? This is just one example taken from a very recent WHO Europe report on the healthcare workforce crisis in Europe that WHO Europe describe as a ticking time bomb. This is for Europe. And then when we heard about Osahon's statistics about Africa, if it's a ticking time bomb for Europe, it's exploded in other regions around the world. But this shows you very, very, very clearly how where there are more healthcare workers, people live longer. So it's not just about it's not just about a quality experience of healthcare and safety in relation to some of those other issues. Absolute bottom line in terms of mortality rates are affected here. Next slide, please. We have just celebrated the 12th of May, which is International Nurses Day, and we set a theme for this year, which nurses around the world follow, called Our Nurses, Our Future. And we have produced a 10-point charter for change that we're calling for all countries and all governments to follow. Next slide, please. To address this lack of investment, lack of support, the dehumanisation for the healthcare workforce. I'm not going to go through all of these, freely available on our website. It's our charter for change, but I am going to read to you, and if you want to download it, it's as simple as that. But number 9, just to share with you the specific words around protect vulnerable populations, uphold and respect human rights, gender equity and social justice. Place and uphold nursing ethics at the centre of health systems design and delivery, so all people can access healthcare that is equitable, non-discriminatory, people-centred and rights-based, and without the risk of financial hardship. So going way back to our code of ethics, but coming right up to date to this International Nurses Day, people-centredness is at the heart of what we are campaigning and advocating for. Next slide, please. And I'm very nearly at the end. This just gives you a couple of examples of projects that we've been involved in, which I think go beyond nursing, but show public support for the role and the work of nurses. The BBC came to us and said, can we do a project with you to showcase examples of nursing innovation, patient-centred practice right the way around the world? Of course we said yes. You can go and access, there's about a dozen films that the BBC produced and beautifully filmed of nurses right the way around the world. But this is how the BBC, when they looked at what nurses are doing now, this is how they categorised the role of nurses. And I think that perhaps one of the positive things from the pandemic is that some of the traditional stereotypes that we have suffered with as nursing as being angels, as being handmaidens to our medical colleagues as well, have been knocked to one side. People have seen a different reality of nursing, which is a good thing. On the right-hand side, your right-hand side, this is a poster from a campaign led here in Switzerland by the Swiss Nurses Association. About a year ago, just over a year ago, they used the referendum system that exists here in Switzerland to bring forward a public vote on significant more investment in the nursing profession. Government here said, you're only doing this because on the back of the pandemic, we can't afford it and we don't think that you're a special case, in a nutshell. It went to a public vote. You have to get an overall public vote. You have to get the majority, the overwhelming majority of the cantons to vote in favour. The public voted for the nursing initiative here in Switzerland. One of my takeaways from this is that I sometimes think that the public, patients and the professions are ahead of the politicians on the need to invest, protect, support and invest. That's it. Thank you very much.
Thank you, Howard. I think it's very visionary viewpoint to take. Just to let you know, the reason why the order of this speakers has been organized isn't sheer accident. We're following the Swiss cheese model. What this means is that if you buy Swiss cheese, it's full of holes. Yeah? And if you line up 12 slices together, what happens is you can't pass a line through all the holes. It will stop at some slice. So you'll have a hole to 1 or 2. In this way, if there is, as the Global Patient Safety Action Plan says, the pathway to failure or harm, patient harm or lack of compassion, then if it doesn't happen at the doctor's side, then the nurses may check it. If it bypasses the nurses, then comes the pharmacist. That's the last point of call in this cycle. That if there is any last-minute error to be stopped, then it is at the pharmacist level. And errors do happen, we are human. This is why it's been there. So the nurses pass on and then the pharmacist. And now I ask Dr. Catton Duggan, who is the Chief Executive of the International Pharmaceutical Federation, FIP, to come in. And firstly, we must thank the pharmacists for being the photo emergency service during the pandemic. They did absolutely everything, from basic delivering food parcels to blood, plasma to medicines, and over and above, reassuring us. I think the community touch was very necessary. So this is the last slice in the Swiss cheese. Yeah, if we don't stop it here, then we have an issue. Thank you, Catton. Over to you.
Thank you so much, Kawaldip, and also IAPO. Congratulations on your 10th Global Patients Congress, and it's a huge pleasure for me to be with you today, albeit virtually. I hope to catch up with some of you over the days ahead in Geneva, where I will be. Thanks as well to my colleagues from WMA and ICN for speaking ahead of me. I know that time is short and brief, so I will proceed. My name is Catherine Duggan. I'm Chief Executive Officer, and I am a pharmacist leading the work of FIP globally. Next slide, please. So we thought it would be good to really give you a little overview about FIP. We were founded in 1912, based in the Netherlands. We're a global federation of national associations, around 160 national associations representing 4 million pharmacists, pharmaceutical scientists, and pharmacy educators around the world. We're a non-governmental organisation in official relations with the World Health Organization since 1948. Our vision is for a world where everyone benefits from access to safe, effective, quality and affordable medicines and pharmaceutical care. And today, during this brief segment, I'm going to highlight the fact that whilst that may be a vision and it's particularly laudable, we're not there yet. We saw that even more sharply focused with the pandemic and the accessibility to the vaccines. Our mission is to improve global health by supporting the advancement of our profession across practice, science and education. But I also must say that we know we cannot do that alone. And I think the pandemic, drawing on that as an example of where never before was collaboration needed on such a level. I want to just make a couple of points before I go on to showcase what the pandemic kind of taught us and showed us, as well as what our work on self-care with patients really involves. So Kawaldip mentioned at the beginning that there's no healthcare without a healthcare workforce. That was a mantra that was laudably mentioned by WHO in 2018. And we know that we all need to play our part in delivering healthcare, but we all need to be recognised as valuable healthcare professionals within the global healthcare agenda. And we all need to be regarded as valuable. And I think Howard makes a really good point when he says this resilience word is bandied about as a bit of an insult, where we've forgotten that the people delivering healthcare are also individuals themselves, and they're also people who live in families and communities. And it's really important for us as healthcare professions to make sure we sound and we feel and we are part of our communities and part of the family of healthcare professions, but also the global community as well. Many of our professions have ended up being patients during COVID, as well as treating patients during COVID. And it's worth us noting that no one has left the pandemic without being altered in some way, shape or form, whether that be what you've seen, what you've been practicing, or whether you've been touched by the mortality brought by the pandemic. Next slide, please. I wanted to pay a big tribute to working in partnership. So my colleagues in WMA and ICN will know that we are part of a really great alliance of World Health Professions. The alliance is made up of medicine, nursing, pharmacy, dentistry and physiotherapy. And all 5 professions really work in a synergy and a synergistic way. In FIP, a lot of our work is regarding the medicines through our science and through our industry and through our innovations through new molecules. But additionally, most of our work that is on the front line not only is concerned with managing the medicines that everybody needs, but also with managing and promoting self-care, whether that be through sexual health and well-being, digestive health, respiratory health, pain, other things that may impact somebody who's already taking medicines or keeping themselves healthy so they don't need medicines. We've got 21 FIP development goals that line up to the Sustainable Development Goals. And these particular areas of self-care touch upon many, but the 3 primary ones are those that you see on your screen, numbers 18, 14 and 19, which really think about safety, medicines expertise, and about the patients as well. Next slide, please. It's really important as we start to build our tools and our resources to support self-care in all the communities that our pharmacists serve, that we also think back about what we have done so that we don't duplicate. We've also got a big programme of digital events, and I must say, things to do with self-care were the highest attended during the pandemic because, as Kawaldip mentioned, the pharmacies stayed open, and day by day, week by week, that evidence base and that knowledge base was changing. And pharmacists like to be quite certain in the knowledge that they have so that they can give consistent advice. Goodness me, we had to adapt and think on our toes. Next slide, please. I thought it was really important to take the learnings from the pandemic because today it's all about partnerships and compassion and being the right professions at the right time, but also how we can share with each other what went well, what went badly, not only for the next pandemic down the line, but really the pandemic of misinformation is one that we're all immersed in right now. And the pandemic of exhaustion and overwork seems to be one that our professions are absolutely drowning in at the present time. So I thought I'd take a couple of minutes to walk you through the things that pharmacists were doing during the pandemic. We realise that the pandemic has now, in the last week or so, been announced as the emergency status has been stepped down. And that's about 1,200 days since January the 30th, when it was announced as an emergency situation. So that's 1,200 days that our professions have been working with their shoulders to the grindstone, helping, supporting and managing during the pandemic. Next slide, please. We did 1,000 days of COVID at FIP, and we aligned that to more or less the 4th anniversary of the Astana Declaration last October. 25th of October 2022 was 4 years since we all signed up to the notion of primary healthcare. And at that time, the 10 global threats included an influenza pandemic, frail primary healthcare systems, and vaccine hesitancy. Little did we know that 1 year later, we would be in the midst of a big global pandemic. Our fragile primary healthcare was going to be made more even fragile. And additionally, we knew that vaccine hesitancy has now gained a pace. The new pandemic, we would call it. Next slide. So I'll just walk you through the 4 areas that we undertook in the pandemic ourselves. Very clearly here, we had to cover all the evidence bases. We had to gather all the studies that were being published week by week, day by day. We had to share good practice. We remember the days when one country was in the midst of the emergency and then the next country could learn from it. That soon evened out after about 400 days. And you can see here all the rows that lead you to the response that FIP made. Next slide, please.
1 minute.
Next slide, please. And here we had supporting our members through the pandemic. I'll leave you to read those. And then I'll skip quite quickly through the remaining slides. Next slide, please. It really sobers me to think that these are the years that have gone by since the pandemic. We created a visualization and a compilation of evidence across the 1,000 days that really helped the profession, and they were able to showcase that back on their membership websites so that everybody could see what was going on at the time. Next slide, please. And you can see here that we had the 1,000 days of the pandemic, a big portion in the middle living during the pandemic. And as Howard mentions, perhaps we didn't do enough reflection at that point about what emerging from the pandemic would look and feel like to the professions. We now find ourselves in a very similar position to Howard, where we're working on mental health in the profession, resilience in the profession, supporting our profession as they really feel the impact now, longer term. Next slide. And this is our global survey as we went through. This may be a model for others to learn from and to build on, and we'd be very happy to discuss this with you. Next slide. Finally, we pulled out 51 responses from the 6 regions that really covered the advocacy, the adoption of technology, the best practice and support, and the science and research. And thinking about your earlier session this morning, we think that these 4 areas really form the bedrock for learning for the next pandemic. But it can't happen without our workforce. It can't happen without our professions. So it's really important to put them at the heart of all of this. Next slide. I've listed here all the roles of the pharmacists. I think you will all know that. A really vital role remaining open in the community. The light stayed on, first point of contact for easy access. Pharmacy on the front line, but also on the front line with our other healthcare professionals in hospitals, in other sectors. And really adapting and responding to the changing world is what we do every day. But in the pandemic, it seemed to be even more heightened. Next slide.
Catherine, you've got...
I think we can
your
skip
time.
right on then. Let's move on. Next, go right to the conclusion slide. You can see these 10 areas. And this has really led us to, and I'll conclude here, Kawaldip, that we always had thought about sustainability of services as our 21st development goal. But actually thinking about the pandemic, thinking about the frailty of our primary healthcare systems and the fragility of our communities, not only with climate change and natural disasters, but also wars, we realise that this has to become a priority goal for all. I'll stop there then. Thank you very much for your attention and apologies for running right to the wire.
No. You deserve that. You do deserve that right to go that extra mile. I think you had a long story to tell because, as you know, FIP was formed in 1912, even before the WHO. So you have a long history of pent-up aggression, experience, and knowledge to share. So we did allow you for that. It's the old days. Seniority comes first in our culture. Thank you. Okay, now next session is that, okay, we did stop with stopping dehumanized healthcare, uncompassionate healthcare, maybe at the pharmacist level. But then what happens next? How we build that compassion back in, it's the elephant shapes its environment, it's not that environment shaping. The elephant actually actively shapes the environment. So this comes to how can patients shape that environment ecosystem? How can we produce tomorrow's doctors who understand us? How can we influence and how can we bring this attitude and beliefs in that? Professor Lara Bloom from our own board member, but also at the Ehlers-Danlos Society, has got some answers for it, especially how they work closely as in rare diseases when you have nobody out there except the patient. There are no textbooks except a living textbook, which is the patient, and the physician researcher has to learn from it. Lara, over to you.
Thank you so much. I'll try and go very, very quickly. My slides. Thank you. Next slide. Next slide, please. Thank you. No conflicts to declare. Next slide, please. Okay, so I'm going to talk about really this through the person impacted by the condition or disease, through that lens. And historically, we've always called that person a patient, and I'm going to explore that and whether that is appropriate still. But the concept is nothing about us without us. This is a very well-known phrase, and I think it's at the absolute core and center of when we think about why people who are impacted by these things should be around the table as equal stakeholders. Next slide, please. I want to take us back to what the definition of a patient is, and it comes from Latin, to suffer or bear, and it means that that person is truly passive, bearing whatever suffering is necessary and tolerating patiently the interventions of the outside expert. The healthcare professional is the healer, while the recipient of healthcare services is the healed, and does not need to take a part in any decision-making or in any thinking about alternatives. And I think that is what we really need to steer away from and why we should think about a new term when we're thinking about this group of people. Next slide, please. Then the term expert patient came along, and it's really, I'm delighted to say, had more and more momentum over the last 5 years. but it was first appeared in a report presented to the UK Parliament in 1999 as a healthy citizen initiative to help deal with chronic illness. And then it was further developed in a report by the UK's Department of Health. And it suggested that expert patient programmes in the UK should be based on developing the confidence and motivation of patients to use their own skills and knowledge to take effective control over life with a chronic illness. We've come a long way since when that was termed, but it has been around for a while and it's taken many years to get to where it should be now, and I hope it only progresses. Next slide, please. So let's think about patients. They are the only individuals present during every consultation and treatment. That's what we really need to remember here. Next slide, please. But we're so much more than patients. You know, we're parents, siblings, children, professionals, CEOs, musicians, carpenters, everything in between. So you're patient when you are in front of the doctor receiving healthcare, but when your opinion and your experience is taken into consideration, it's much more than that consultation with a healthcare professional. It's how it impacts your life, your family, your relationships, intimacy, mental health, and everything in between. So you need to take much more of the illness and the disease and the condition, as you opened with that quote, and remember that this is a whole person and it must be humanized. Next slide, please. So I pose, should we find a new term? When we're talking about these advancements since 1999 of when the term patient expert, patient engagement, patient advocacy, all of these terms have taken such momentum, is now the time to think about a new term? And what are the alternatives? You know, we need to think about people outside of the doctor's office, but have we come too far to risk the progression that there has been? And do the people involved actually mind being referred to as patients? I don't have the answers to these questions, but I think it's important that they are asked and that this conversation continues. Next slide, please. So I'm going to talk a little bit about how our organisation, the Ehlers-Danlos Society, which represents globally people impacted by the Ehlers-Danlos syndromes and hypermobility spectrum disorders, which is a group of genetic connective tissue conditions, how we have really taken the voice and the experience of people impacted by our conditions at the centre of everything. And the last time the diagnostic criteria was penned was in Villefranche in 1997, and there was 20 long years of neglect. And it took a patient organisation, the Ehlers-Danlos Society, to work with others to bring together the first diagnostic criteria published in 20 years. And since that moment, and when the Ehlers-Danlos Society was launched in 2016, there's been a huge progression, and we are now evaluating that criteria already to see if it needs to be republished, and that work is being driven by patients. Next slide, please. So we had the concept of an international consortium introduced in 2012, and all of the healthcare professionals knew the importance of bringing together all the people working on all the 14 types of EDS from around the world, but there wasn't the time and the capacity for them to do what they needed to do. And again, it took patients to say, okay, the patient organisations, EDS UK, EDNF, and then that came together to form the Ehlers-Danlos Society to say, we know what needs to be done because we're representing the people this impacts. We know that because there hasn't been an updated diagnostic criteria for 20 years, people aren't being diagnosed. People aren't, feeling validated and heard. So this is an example of how from 2012, it then didn't come together until 2015, and it was through the direction of the patient organisations that happened. Next slide, please. Next slide, please. I can skip this one. Okay, so this international consortium is a group of about 150 healthcare professionals that covers all the different comorbidities and types of EDS. And in every single one of those working groups, we have a patient voice. That was absolutely essential to us from the start, and so they have been published in all of the articles that have come out from the consortium. And it's this group of people that have contributed to the new criteria, to updated publications since then, and it's truly amazing to see how much richer the work coming out of this group is because that patient voice is there. And we encourage other consortiums and groups like this that are always thought of being made up and comprised of healthcare professionals to have that person who is living with that condition as an equal stakeholder around the table, not just as a checkbox at the end to come in and say, yes, this is the right direction. Let them form the direction with you. Next slide, please. Another example of how we included the community themselves is through our HEDGE study, the hypermobile Ehlers-Danlos genetic evaluation. There's 14 types of EDS, one without the known pathogenic variant, and we knew we needed to find that. So we got all of the patient stakeholders together, and we helped work out how the best way that we could do this was. And we actually ended up enrolling 1,000 people from all over the world during the pandemic to have whole genome sequencing, and the analysis is going on at the moment. And it's already showing some really promising. Next slide, please. We also have our Community Coalition, which is a group of people impacted by the conditions, other patient organisations and healthcare professionals that all work together to work out research priorities for this community. Another great example, we've had some grant funding from PCORI in the US to help this work, and we've also had 3 publications come out of this group. Next slide, please. Another great example is in March 2020, I was very privileged to be appointed a professor of practice at Penn State College of Medicine in patient engagement and global collaboration. To our knowledge, it's the only appointment like it in the world. There should be more. This kind of thing should be professionalized and encouraged. And I'm very proud that exists, but I wish there were others out there in other parts of the world. So big props to Penn State College of Medicine for making that possible. Next slide, please. There's my contact details. I think I did it in time. Do I get a prize? Great. Thanks, everyone.
Thank you, Lara. That was, you saw how the patient organizations have influenced change and have educated or changed the environment. Our next speaker, I think this is 2 groups again. This is where they're saying, you know, that let's put research into practice. You know, everybody says that, you know, let's put research practice. But then what about closing this loop? Let's put practice back into the research. That once you've done something, you have to come back. And this morning's session, when we had real world evidence being discussed and your party and others, that was the same issue. Very often we forget to ask what has happened, where it is. And I think, again, Tessa Richards asked what happened to those vaginal mesh scenario. Did anybody monitor those? Did you ask those women who had the mesh what's happening and report back? There was an oversight in that. So next speaker is Nicola Bedlington. Nicola, many of you will see she's now wearing different hats, but she's CEO of the European Patients Forum before this, very widely respected across the WHO region. She's also very, as a foundation of our own and also partnership. Nicola was very instrumental in helping us work with our partners at Roche and others to develop international experience exchange with patient organizations. And one of the position papers that this collaboration brought was humanized healthcare. Please do access the paper. And there were points that we put forward that this is the way possibly to go. And this paper came through to an intense pandemic. You know, we were all shaken up and we said we need to do something. So I'll ask Nicola to come and say a few words and then explain why it's important for us, and do access that paper. Nicola?
Thank you very much, Kawaldip. You asked me not to have any slides, so I'll just stay here and I will respect the time, no fears on that front, because I think we're probably ready for a good discussion as well. As you mentioned, I am a member of the External Advisory Committee of the International Experience Exchange with Patient Organisations, IAPO, as you are, Kawaldip, and we also have another person in the room, Dr. Sowson, who's also a member of that advisory committee. Established back in 2009, IAPO is now one of the most influential patient community exchange platforms worldwide. And over the years, it's actually evolved from being an annual event to an ongoing dialogue and co-creation of tools and resources that are actually made with the community on the basis of their defined needs. The IAPO position paper on humanising healthcare is a call for transformational change. It was published at the end of 2021 and it really puts patients at the heart of healthcare. Humanising healthcare means building systems around the needs of people and patients. And it represents their needs when it comes to healthcare decision-making, service design and ecosystem transformation. To really address some of the structural design and ecosystem issues and problems, the fundamental ones that we've heard about so eloquently today, that were indeed put into very harsh focus for healthcare professionals, but also for patients, for citizens themselves during that very, very complex period. But also to drive forward universal health coverage. This really matters to the patient community as it does for other stakeholders as well. So the position paper essentially is looking for a compassionate mindset that really brings patients, healthcare professionals and other stakeholders together for more trusting, equal partnerships, for more holistic care based on the goals of patients and the outcomes that really matter to them. The position paper is actually based on a survey with over 300 responses from patient leaders from across the globe. Also with a lot of reflection from the International External Advisory Committee linked to IAPO, and this brings together perspectives again from across the globe. It posits that humanising healthcare can enhance access and parity of health across the globe, support empowered patients really by enabling them to take ownership of their health and care and lives. It leads to better population health because of the focus on prevention, and ultimately it also leads to more sustainable health systems because it's actually reducing waste for investment in the places that it's needed. The position paper covers 5 key areas or chapters. First of all, putting people at the heart of healthcare, and this also looks at compassion when it comes to healthcare professionals. Some of the issues that we've heard about this afternoon already: burnout, depression, the need to exit from the profession because there doesn't seem to be any other way forward. The second chapter is looking at humanising health literacy, looking at, for example, the role of health literacy in shared decision making, but also looking at the democratisation of science. Those are just 2 examples in a very expansive chapter on humanising health literacy. The third area looks at humanising digital healthcare to build capacity by harnessing the power of data. It positions, and this has been heard very much in this town as well, it positions digitalisation as a key determinant of health, and it calls for responsible, and I underline responsible, health data sharing for better research and more effective decision making. The fourth chapter is exploring humanising healthcare to focus on both prevention and cure with a 50-50 investment model, a new social contract with a big emphasis on primary care. And again, we've heard today how important that is. And the final chapter focuses on prioritising diversity, equity and inclusion to humanise approaches to healthcare, to really address stigma and discrimination, but also to reach out effectively in new ways to underserved communities, using the premise of meeting patients where they are and leaving no one behind. So patient leaders across the globe, patients that are involved in the APPIS community, using the position paper and related tools and resources to have a different, more progressive conversation with healthcare professionals, with other stakeholders, and significantly with policymakers to move forward together. And I think a lot of what we've had included in this position paper resonates with everything that has been said today so far. And I'd just like to make a comment about Lara's point about, are we using the right sort of terminology? Is patients really the right sort of word now? And I'm going back to some of my time at EPF when we were preparing our strategic plan back in 2014. We had a lengthy debate about should we actually find something else to describe our community, our movement. And at the end of the day, we said actually people see us as the European Patients Forum. If we change that identity, then maybe we're actually missing something there too. But I think it's a really excellent debate and a very, very timely debate as well, and very linked to the whole humanisation piece too. So over to you, Kawaldip. I think I've kept to my time. Thank you very much. One last thing. In order to find more information about this position paper, please do visit the website www.IAPO.com, that's IEEPO, and it's also crucially available in many other languages. Thank you very much.
Thank you, Nicola. As I say, this paper was just the start of that thought process, and it's in the middle of pandemic. I think I'm glad the paper is developing legs and wings soon, and it will travel amongst policymakers and have them thinking about it, and hopefully it implements into real changes. It was a case of changing the hearts and minds of people, I think, and bring back the what Ottoman has always said, that closeness of the physician and the patient, that old-fashioned relationship that was there. My next speaker is Rod Padua now. Rod is coming from the other side of the issue, from Asia Pacific, Middle East and Africa. This is about how do we share innovation in this region. As you know, the journals are far and few in between for us to share our best practice. It almost becomes like an oral tradition, you started sharing by word of mouth. And the APPIS, which stands for the Alliance of Patients for Prevention and Solution, was set up for this reason, to ensure that patients who live and access healthcare in these regions can have their say and share the best practice, and have that best practice transformed and heard within the policy makers' chambers. When the NHS was formed in 1948, one of the health ministers said, I'm forming this NHS in such a way that if there's a bedpan falling in Duggan, Duggan is the middle of Wales, in a small hospital in Wales, and the fashion of having bedpans, that if the bedpan falls in that hospital, then the clangor for that falling should be heard in Westminster, where the members of parliament are sitting. So that is now possible actually through Zoom and others. You can almost, with AI and machine learning, that bedpan could be caught midway through. In fact, the minister could stop it even falling over. So I'll ask Rod Padua to come in. Rod, over to you. What APPIS is and what successes you have had and what's your next program. Thank you. Rod, you're on mute, I think. Team in India? Just bear with us. All right, meanwhile, I just want to share with you that lunch will be served in the next building. So just while they're coming up, so we probably. I've been asked to arrange a photo shoot. How did they want to do that? Was it lined up here? Okay, sorry. So they said if you pass through to the coffee area, we'll line you up and then we quickly go into the next building for the food. And the photographer is at the back there. So we'll make sure that we're there. While Rod is... okay. Is it now? Okay, Al-Hamody can't join in? Mahmood can't join in too? Okay. In that case, whilst we wait for these technical changes to happen, can I call Dr. Ifan to please come over? As you said, we must influence the change in the future generation. Dr. Ifan is a chairperson of the external relations with the International Pharmacy Students Federation, IPSF, and I think, please do sit down. And we would like to have that student element here. How can we influence students and how can they help us change this? I anticipate the issue beforehand and cultivate good plant. And I think those who come from areas where we do produce wine, you know that good wine begins 20 years before that when you plant a good stock. This is our good stock.
Can you all hear me? Okay, perfect. So thank you so much for the question. And I also got the prompt as to how we think young pharmacists have a role in transforming the health of communities and also in pandemic preparedness. So my answer will be tailored to that. I have 3 main points that I would like to deliver, and I would like to say that as a young pharmacist and also young pharmacy students representative, we make up a huge part of the healthcare workforce. Just within my organization, which is the collective voice for international pharmacy students and recent graduates, we represent over 500,000 of our members. So that means there's at least that much in the world that can contribute when there's a health emergency or when there's unexpected things that come up. So for us, we can play a huge role in terms of education. When working in the community pharmacies, we see a lot of patients. And for example, during the pandemic, we have seen a lot of misinformation myths that came up, especially surrounding vaccination and how COVID should be. So as young pharmacists and students working in the communities, we were able to talk to many of you about the different things about COVID and also about the vaccinations to dispel all those myths. And I also think that we play a huge role in terms of contributing to the workforce as vaccinators. So a lot of us got trained in vaccinations. So we were able to deliver many millions of vaccine doses during the pandemic as well. So that's another piece where we can come into play. And another thing is we are also actively involved in the testing and contact tracing as well as research, which all helped to contribute to the vaccines and also the just in general preparing for the pandemic. And lastly, when the pandemic hit and also when future similar things that can come up, pharmacies play a huge role because we have a limited amount of drug supply, and it's important that we distribute and not have kind of hoarding issues. So we were able to talk to many of the patients who come in and cooperate with all of you to ensure that the sufficient supply is remaining so that when people who really need it the most can still access it if they cannot come to the pharmacy at the very first moment. So these are the things that I think would definitely make us very important in terms of preparing for the next, hopefully not, but for the next pandemic and health emergency. And also, yes, from what I've seen, many of my colleagues have worked throughout the pandemic, so that's definitely something that we have been contributing. The other part is, as pharmacists and pharmacy students, we are in many of the communities, and we're in much greater proximity to a lot of the rural communities and also a lot of you. So we are typically known as the most accessible healthcare professional. So a lot of the questions come to us first. So for example, even during the pandemic, a lot of people, even myself, we got a cold and we're wondering, is this COVID? And we would go to a pharmacy to ask that question. So as pharmacy professionals, this would be a great way where we can spread correct information. And my last point is we are very diverse. We also can take on many of the health initiatives, and we're very adaptable and innovative. So during the pandemic, I have colleagues who have invented a new initiative where there's 3D printing of the face shield, and that was distributed for free to the communities. We have also created a virtual platform where we transformed our practice from a walk-in basis to a scheduled basis so that everyone who requires vaccinations or testing can come in at the right time instead of having to line up for hours outside the pharmacy. So there are lots of different things that we're able to do, and all of these, we do that with all of you and patients in mind. I know there could be a better term, but for now I will refer to patients. But yes, our job is to...
Thank you. I'm sorry to put you into
No
pressure
worries.
to fill the gap. I know
Yes.
it's past professionalism at heart. You're a great one. Rod is back online. Rod, can we go ahead?
Yeah, I'm really sorry, Kawaldip. You know Murphy's law. If something will go wrong, it will go wrong. Apologies to everybody. Well, foremost, a quick thank you for the organizers for allowing APPIS to share its story in this Global Patients Congress. Let me make it up to you. Let me introduce myself briefly. I am Rod Padua. I am the Strategic Advisor and Council Member for APPIS, which is the Alliance and Partnerships for Patient Innovation and Solutions. I am also the chair for the Chronic Myeloid Leukemia Network and the president of a CML and GIST advocacy organization in the Philippines. But more than anything else, I am a caregiver for my son who has had CML since he was 9 years old. He's now 25. Next slide, please. Next slide. My presentation will flow in this manner. First, why was there a need for a platform such as APPIS? I will then introduce what APPIS stands for, then a deep dive into its activities and components, and its journey in numbers, highlighted by a memorable quote by one of the participants. Lastly, I will close and leave you with a short inspirational video about APPIS. It's a short one, don't worry. So why was there a need for a platform such as APPIS? Next slide, please. Basically, three focus objectives: to help address barriers to accelerate access for patients, to build strategic partnerships among a dynamic patient community, and to leverage on digital technology advancements to ensure that patients' voices are amplified and heard. So next slide, please. Let me take this opportunity to discuss what AP stands for and how we live to its meanings. A in AP stands for Alliance. We are joined over the course of the year because we have a shared goal: to improve access for patients. We have come together as an engaged community from across the spectrum of healthcare to address common challenges faced by patient organizations in the Asia Pacific, Middle East, and Africa regions. This is so that we can share experiences, discuss solutions, and better equip the patient community to be more impactful in the healthcare system. The first P in APIS is for partnership. Partnerships are so important when we think about how to deliver better outcomes for patients. We all know the saying that two heads are better than one, and when it comes to something as critical as accelerating access to patients, we need as many stakeholders as possible to really make a difference. APIS is about bringing together different experiences and perspectives so that we can work together to overcome the barriers and challenges faced by so many patients. The second P in APIS is for patients, the heart of everything we stand for. I cannot overemphasize how patients play an integral role in the healthcare system. Health is a very personal journey, and I'm sure we all have our own stories to tell about knowing patients or perhaps being patients ourselves. AP seeks to help amplify patients' voices and make sure they are heard. I is for innovation. We know that most industries have entered an era of hyper innovation, but none more so than in healthcare. In healthcare, an innovation is a development, simple or complex, that leads to improvements in health outcomes and patient experiences. It is our hope that advocacy leaders benefit from this wonderful community of brilliant thinkers and live with ideas to take their own innovations to the next level. And finally, we have S for solutions. We strive that our participants walk away with much discussed proposed solutions that will accelerate access to medicines and diagnostic tests. At APIS, we recognize the importance of patient-centric solutions and, and involving patient advocacy groups from the very start. Next slide, please. For the first 3 years of APIS, we focus on health literacy, health policy shaping, digital health, and communications. Three key themes we believe has so much room to grow in terms of patients' knowledge in the regions of Asia Pacific, Middle East, and Africa. Next slide. APIS is not only a one-off summit event. Rather, it is basically a whole range of events and articles for advocates and patients. So aside from the APIS summit, which I will glance on the next slide, we also have APIS X, which are specific country engagements to address issues locally. We also have the Innovator Program for patient organizations to scale further their existing initiatives. We actually had two winners last year. And for this year, 2023, we had 31 submissions from 16 countries. And the council is currently evaluating the top 5 entries. Finally, we have curated resources and other references in the APIS Resource Center, fully downloadable for anytime use. Next slide. The APIS Annual Summit was held virtually for the past 3 years. For this year, we have more than doubled the number of participants from the previous year at 1,434 from 60 countries. Out of the total number of participants, we had 57% as new logins, meaning we are garnering more and more interest from the whole health ecosystem. Next slide, please. Included in this list of attendees are patient leaders and their organizations, HCPs, policymakers and the government, technology experts, media, and pharma. Next slide, please. APIS numbers include the cumulative total of about 2,000 plus participants in 60 countries. And leaving you with the quote, next slide. Of course, the numbers tell our successes. It makes us strive for more achievements. However, at the end of the day, it is the impacts to patients, what they tell us, that makes our day. These are the lasting things that inspire us to reach out to the other patients out there. Like what this woman said, a leader of the Multiple Sclerosis Society of India, in 28 years of advocacy. It is only during APIS that she was able to exchange ideas and learn from other patient organizations. Next slide, please. For any feedback, we are just an email away. And please do visit our website at appisinitiative.com. Thank you, Kawaldip. And I apologize for having gone a little over time. So now I'm leaving you with a short 2-minute video of APIS.
Thank you very much, Rod. Such an inspirational discussion. I think we were so happy you could join us and stay with us. And I'm sure my colleagues from Africa sitting here, basically, please do access this and join up APPIS. It's very important to have you. And colleagues from Middle East as well, and Asia Pacific as usual. I thank you, Dr. Mahmood, for patiently waiting whilst we had this little hour. I have to ask you this question. Firstly, congratulations to the IFMSA, the Federation of Medical Students Association, for having produced a keynote, excellent policy document for patient engagement in medical education. This is the first document that actually refers to patients as educators. And coming from young doctors, it was really appreciated by us. We really were happy. And our last board member, Dr. Weinhold from Germany, was pushing this with Stinger from IFMSA. The question that we're asking from Dr. Mahmood is, what are the benefits that you perceive for both the future doctors and patients from this approach of putting patients as educators and putting patients within medical curriculum design and within medical training positions other than just being subject matters? I know my uncle always quotes this example of UCL, you know, when they were training as doctors, they used to have randomly placed patients in cubicles, and you had to go and talk to them and diagnose what condition they were, and thereafter never they saw this patient. And then it turns out the person he was interviewing was somebody who lived down the road. He said, I should have talked to him over the years far much better. So what's your opinion, Dr. Mahmood? Could you tell us, how do you see IFMSA and helping future doctors and patients work together? Thank you.
Thank you so much, Kawaldip, and good afternoon, colleagues. Unfortunately, I couldn't join you in Geneva yet because of visa issues, but hopefully I will be there in the upcoming week. This is a very important question, and before answering it, I would just like to lay the ground for it. There are very little comparisons between healthcare and business in general, but there is something that we need to learn out of business. In business nowadays, there is a huge focus on user-centered design or customer-centered design. Designing, let's say, or developing interventions and services and packages to the needs and wants of the customer, to the needs and wants of the user. In business, it is for the increase of profit. But when we think about healthcare, it's about high time that in a humanitarian field, in a humanitarian, if we may call it business, that focuses and puts people at the center of it, that healthcare should shift its focus towards patient-centered design and people-centered design. Now, from the perspective of the practitioners, patients are part of our education and are a part of our training throughout the different spectrums, from the very starting point till the last point. Part of our education is based on books, it's based on literature, but a huge part of it is based on practice and is based on interaction with the patients and with people. Patients have always been involved in medical education. They have usually been used to provide passive experiences of the diseases. But then it's very important that we shift this passive experience or passive involvement of patients to more of an active role in the process for several benefits that we will try to elaborate more on about. Now, from the perspective of the worker, healthcare worker, I will not limit it only to doctors or future physicians, because these benefits really apply to the spectrum of the workforce. Involving patients in healthcare education not only help the students and the future workers to acquire skills, whether it's communication skills or whether the clinical skills required to deliver the service, but it also helps emphasize certain attitudes towards the patient, to emphasize and strengthen the patient-doctor relationship or the patient-worker relationship, once again, to be more inclusive. And it also helps strengthen the cognitive understanding of the how the practitioners should accommodate for the needs of the patients, how should they understand the context of the patient that they come from, and adapt the service delivery to their context, to their needs, and also to their specific health conditions. Now, from the perspective of the patients, it's very important that we understand that while, yes, involving patients and the education of the workers is very important for the workers to emphasize their skills, to hone their skills. It's also very much important for the patient experience of the spectrum. Patients, while contributing to the learning experience of the healthcare professionals, this also helps emphasize their feelings or their attitudes towards healthcare workers, and that is very important. This goes both ways, both in implementing or solidifying the attitudes of physicians or healthcare workers, and also in solidifying the attitudes of patients toward each other. This emphasizes and helps in building stronger bonds and stronger relationship between the patients and the healthcare providers. And this is essential for the delivery of the service. Now, in addition to that, the involvement of the patients in the educational and training of the workers in a, of course, humanized manner is very crucial for both the physicians and also the workforce to develop an understanding of how to assess the needs of the patients, how to address their own context, but also for the patients to understand more about their health conditions. One of the lived experiences that I personally had and during our training years was that when we used to engage with the patients in the ward, we used to discuss the condition in front of them. And they used to engage with us in the discussion, trying to understand further about their condition, helping us with several other inputs that they gained from other students that have passed before us. And engage with them. And this is crucial for the learning experience. This is very valuable. Without that part of the experience, without getting that feedback and input from the patient and understanding, okay, that the previous discussions of the previous students included 1, 2, 3 points, and then the professor elaborated in this way, and in linking it with the way we are thinking, we reach out to the certain conclusion regarding the health condition. We do not have the outcome of our learning process. We will still dwell in our own understandings and thoughts. Now, I would just like to finish with very important conclusions, if I may, Kawaldip. Once again, patients have always been involved in medical education and in the training of the workforce, but they have been always passively involved. It's very important that we put patients at the center, not only of the service delivery, but also at the center of the educational process, so that we cater for a people-centered and patient-centered healthcare system. Over and back to you.
The panel session for brevity, because I don't want to stand between you and your lunch. And I think my communications officer is saying there's a photograph she wants to take. So that's a dangerous territory to be. It's like a hippo charging you. Okay. Please, to the panel, I will ask now in less than 2 seconds, 2 sentences kind of statement. And maybe even in your silence sometimes helps, you know, but I'm not a bad, it's sufficient. Okay, to Dr. Osahon, has the pandemic changed the dynamics of physician-patient relationship, and how?
Well, thank you very much. I think the answer is obvious. We've all seen the statistics that we had during the COVID-19 pandemic as to how, in spite of the fact that they were, delivering care to challenged patients, they were buffeted with all forms of violence, all forms of, indecent working conditions and all of that. And that has led to increased exits from the profession and, of course, impacted negatively, on the whole process of patient-centeredness, in terms of the care approach. So there is need for a rebuilding of confidence, in the whole process, because like we said, humanizing the care process, has to be, the whole value chain has to be humanized, including the healthcare professionals. So you cannot have, patient safety, without the safety of the of the physicians and other healthcare professionals. So certainly a lot has happened, and the mental, psychosocial states of the physicians and other healthcare workers was heavily, distorted and impacted. So all of that needs to be brought back by, of course, focusing on rebuilding the healthcare system in a way that prioritizes investments in a resilient health workforce.
Thank you very much. I think this is a quote I've often heard. It's very sad to see a doctor leaving his profession to do something else after frustration within NHS and so on. And it's almost like losing an old tree. We have invested a lot in it. From a taxpayer system, we have educated the doctor and then to see them despondent and leaving, it's very sad. Now to Howard, we heard about the burnout and demoralization of nursing staff. What's the impact been, and what are the quick fix solutions in the interim? I know this is not going to be resolved easy. Is there a quick fix solution you can think of? I know pay alone doesn't work. I know this much. We have really lost trust in them at the moment.
So in my presentation, I included what the quality and the safety implications are, and I think in a nutshell, if there is a dehumanized healthcare experience for patients, almost inevitably it means it's a dehumanized working environment for staff. The quick fix solution, the question is important because actually there isn't a quick fix solution and people are looking for one all the time. An example right now of the rush to a quick fix solution for the failure to have educated enough nursing staff around the world is international migration and recruitment, which is causing enormous ethical issues and considerations, is undermining healthcare systems in countries least able to afford them. So it's not a single quick fix silver bullet, but the things that we need to do are also not rocket science. We know we need to invest in education, decent pay, working conditions, career development, flexible working environments, a culture that respects you and listens to you as well. It's those package of measures. The ingredient that too often is missing is the money, is the cash, is the investment. And I think for all of us, the pandemic has cost the world trillions, and the arguments that we need to make for, you'll hear it this next coming week in WHO about, investment in health workforce is a human capital investment and not a cost. That's a central issue for me.
I know this is very often, I think I heard from nursing staff from Philippines saying that first they gave us COVID and then they took all our nurses away. Meaning that most of the nurses for Philippines were working for European health systems during crisis. Now over to Lara. Lara, when there are no cures available, then the only cure then is that physician-patient relationship. Do you think this is what we should be promoting, that closer working relationship in rare diseases, because maybe if the treatment or drug is 50% of the cure, then the physician relationship is the other 50%. Do you think there is that mileage there to, especially with the rare diseases, develop further closer relationships between the physician? They're already there, but what's your opinion on that?
Yeah, I think so often with rare and chronic diseases, there's no approved therapies. Access to management is very hard. Still, access to care is really largely dependent on geography and wealth. And so often all that people have is the chance to go in front of a doctor, and so often they're not believed. And I think the greatest gift a health professional can ever give a patient is validation, because the average diagnostic odyssey in rare diseases is 10 to 12 years, and you've been bounced from doctor to doctor, not being believed, being told it's anxiety, being told it's depression, it's in your head, and to have a doctor just listen and believe what you're saying and validate your experience can sometimes feel close to a cure.
Thank you. Thank you very much. Now I will go over to Nicola. The European Patients Forum had played a critical role in bringing together and sustaining patient experience and international experience exchange with patient organizations. What would your advice be to health professionals on how to create an enabling ecosystem and community of practice to encourage free and meaningful exchange of patient insights and preferences, and that would add value to healthcare?
You want 2 sentences?
Yes.
Okay, I mean, a lot could be said around this. I think one element that is really, really important is to collaborate with patient organisations to ensure electronic health records are accessible, interoperable, and include patient experience data that are gathered by patients themselves. This is really, really valuable. I think the other piece is, as we move, hopefully, slowly but surely towards person-centred, value-based healthcare, that we ensure appropriate involvement of patients in actually looking at patient-defined outcomes, patient-defined experience measures that really truly reflect priorities and goals of patients themselves. And those 2 elements are really, really important. Data does save lives. I think embracing digitalisation, despite all of the challenges that exist, is really important, and also responsible data sharing in order to be able to support this shared decision making at micro level, but also the collaboration that happens between healthcare organisations, healthcare professional organisations and patient organisations. That evidence base is really critical as well.
Thank you, Ange. Nicola has been modest about some of the contributions. I think you should check the publication Personalized Value-Based Healthcare. Is that what the title was? Please do access that document. It's a fabulous document, how to re-engineer things. And so I think that document's also taking, it's developed legs, it will develop wings soon, I think, in our feeling. Then over to Aoife. Do you think missing out the pharmacists, young pharmacists' view in the pandemic preparedness treaty was a short-sightedness? I think, do you think young pharmacists should have been part of the pandemic preparedness treaty negotiation? That's very challenging one, but you answer that would be great.
Yes, well, to answer this question, one word is enough, yes. We're definitely missing out, but I would like to say that as young pharmacists, we are, again, very accessible. We are very adaptable to all the situations. So there are lots of things that we can contribute to. And in regards to today's topic about patients, I think we are there to listen, and a lot of has already been said. We also learn about quality of life. We also learn about patient-reported outcomes. So there's a lot of things that we do in our services that takes your opinion into consideration, and also our innovation. So feel free to come to talk to us. And yes.
Thank you. That's a good answer. Now I'll go to Rod. Rod, not online. Rod, the question for you was that, do you think APPIS is the model to improve innovation, access to innovation, and innovative health technologies?
Yeah, I think one of the main advantages of multi-stakeholder forums like APPIS is enabling inclusive and participatory decision-making processes. By including representatives from different stakeholder groups, these forums like APPIS can ensure that various perspectives and insights are taken into account when designing policies, programs, initiatives. And this collaborative approach can eventually lead to more effective and equitable solutions that reflect the needs and realities of diverse communities. This is essential for advancing access to innovative medicines and practice by facilitating collaboration and knowledge sharing. Finally, I think it's important to emphasize the fact that patients are the true experts in their disease. with the global campaign initially led by the HIV community, also mentioned by, I think, Professor Lara Bloom earlier, Nothing About Us Without Us. Um, it underscores that what patients need is to start working with them on what matters, rather than working for them and taking decisions on their behalf. And that is what this APPIS is all about.
Thank you. Thank you very much. And now to Catherine. Catherine, this is a complex question. I'll try to simplify it. They say when we speak of personalized medicine, very often everybody talks of the genomic medicine, the digital solution, the genomic issues, all that lab. But nobody has addressed the issue of how do we personalize medicine at the front, which is the pharmacist. Do you think there's a role for pharmacists to play in personalized medicine? Because very often the pharmacist knows everybody. He can't be more personal than anybody else in that he or she has treated generations in that same location. What's your opinion on that? Should pharmacists now be given a seat on this bandwagon there talking personalized medicine? Over to you.
Thanks, Kawaldip. You've got two main issues there. You've got the personalization of the medicine for the patient with the science and the technology and the formulations and basically the clinical use of the medicine. But you've also got the personalization of the experience. And pharmacists do this daily, as you mentioned, and a little bit like what you said earlier on about inclusion, that we're only going to get true personalized medicines for patients and the populations if we all collaborate and play to our strengths. Now, in all community pharmacies, but also in hospital pharmacy, in patient-facing pharmacist roles, they will be seeking to personalize the medicines that that patient is being prescribed, whether that be prescribing or then the quite a strange term, deprescribing, which means taking medicines out of the patient cocktail, all the way through to looking at what they're taking over the counter. For many patients and populations, that is not necessarily regarded as a medicine, and it could well be potent and having an impact on the patient as well. So the whole identification of what's working for the patient, what might not be needed, what could be taken out of the cocktail is what we would regard in pharmacy as the personalization to that individual patient. And despite what pharmacists may be known for, i.e. the medicines, we're also quite a big fan professionally of getting the maximum benefit for the least amount of drugs taken. And that's really, I think, where pharmacists can play an active role. We've got lots and lots of examples, Kawaldip, about how you can remunerate pharmacists for this. Rather than incentivizing them for items dispensed, you can remunerate them for services provided. In addition, if patients know that medicines can be modified or can be taken off the list or new ones can be tried, they feel much more confident. And there's lots of research that shows that. And of course, adherence then increases. And that helps us with the evidence base around what is the actual effect of these medicines when we know how many they're being taken and for what kind of condition. A final point I would make, Kawaldip, is the issue for us to think about trials and involving patients who are elderly as well as patients who are very young. And this is something I think would be a great conversation for the future.
Okay, thank you very much. That's good. Last word, we'll leave it to the International Federation of Medical Students Association. What would you say to health is gathering at the World Health Assembly 76 this Monday, and medical college directors who might be joining them? What would your message be?
Well, the message is clear from the theme of, I'm not sure if you can, my message is clear, and that's based on the theme of the World Health Assembly. The theme this year is health for all, and health should be for all and by all. Health is a human right that should be centered on people as the right holders, should start from them and should end from them. I hope that is very quick. Over back to you, Cody.
Thank you very much, and we'll see you in Geneva soon. I'm sure you'll be joining us. With that, we conclude the session. I hope I brought the landing on time. Yes, I think we're okay. I've been handed a note that we are going to have lunch in the second building, but before going for their lunch. If you could please join us through that coffee area we were having. We'll have a photographer perched up on this balcony. He wants to take a photograph of some sort. But please do step on and we'll keep talking. Let's use the networking lunch for the discussion. Thank you very much, and thank you everybody who's online there. And those virtual, about 300 so virtual audience. Hope to see you next time when in person, when things get better for us. Thank you. And please be back by 2:30 sharp, yeah? 2:30. That tea.